а также образованием плевры. Поэтому разрешите дать слово нашему лектору Данко Костадинов. So, dear professor, you can start your presentation.
Good morning, everyone. Thanks once again for the opportunity to do the last lecture of the 4 that are dedicated to the bowel cancer. Can you see my presentation now?
Yes, we can see it well.
So the last presentation, as we discussed, is going to be a managing of the metastatic and advanced colorectal cancer. I decided to include a little bit of my work, which is dedicated to peritoneal malignancy and the condition called pseudomyxoma peritoneae. So just briefly again, the colon cancer, as we've already mentioned, there's a discrepancy in between males and females, and as well as positioning of the colon cancer, as you can see on the diagram. Just a brief introduction again from the pattern from what is called the 10-year theory of developing a cancer, starting from the early adenoma, going through the precancerous condition, and then the invasive adenocarcinoma. Again, just briefly to remind the audience regarding the stages of the colon cancer, starting from stage 1 to stage 4. Today's lecture will be mainly dedicated to the stage 4 and the metastatic colorectal cancer. As you can see, this is the Dukes and the TNM classification, just a brief reminder of everyone from my previous lectures. Where is mainly the bowel cancer metastasizing? So this is an odd place of metastasizing. I'm just briefly mentioning it, which is in the brain. Usually it's metastasizing mainly in the lymph nodes, which is the lymph node metastatic disease. But there's also hematogenous spread when it's going into the liver, which is the primary site, or into the lungs. And as well, the tumor can start spreading when it goes after the T4A stage and metastasize in the regional organs surrounded. How is the tumor metastasizing? The tumor metastasizing by primarily the tumor circulating cells. And as you can see here, there's a lot of different patterns that are trying to describe the way that the tumor starting, for example, in this case from the breast cancer, metastasizing in the different origins. I want to keep your attention mainly in what is called the micrometastasis, which is the one that the chemotherapy and the immunotherapy is trying to kill. I will briefly have your attention on this. That's mainly the idea of having the lecture dedicated only to the oncological part, which is the chemotherapy. I think it's a part of the oncologist. I will explain how we can do the macrometastasis, which I think is more surgical and non-oncological part. And as you can see on this diagram, there's a lot of different factors that are affecting the cancer cell and the cancer cell cycle. And at the current stage, there is a lot of different options and theories that people are trying to find out how to stop the tumor spreading and how to put the advanced colorectal cancer into a place that we can treat it. The most important organs that you can see from this diagram are being affected is mainly the liver, the lung, and the bones. But as you can see on my first diagram, you need not to forget that the colorectal cancer can metastasize also in the brain. So how is that happening? And what we know up to now is that the different types of the colon cancer, and as we all know, there is not only one colon cancer, there are different types. It's been proven that they can metastasize in the different organs more commonly. And as we know more about the colon cancer, the more that we can treat it and put it on hold. On this diagram, which I'm finding quite useful, is the different histological types are helping us by knowing what to expect from different cancers, because every patient is different and every cancer is different. It needs to be a strongly individual treatment dedicated to every single type. And as you can see here, for example, the adenocarcinomas, which is the most common type of colorectal cancer, are mainly metastasizing in the liver, but also in the brain. The location is also very important, as you can see from this diagram, because the location and the type of the tumor will also develop the area that it can metastasize. I want to keep your attention mainly on the first part, which is the right-sided cancer, which irrespectively of the KRAS status, you can see that there is an associated peritoneal metastasis. It's not very common to have peritoneal deposits from the rectal cancer, which is mainly dedicated to the fact that the KRAS type is usually being affected, as well as the abnormal anatomy, as we discussed before, of the rectum. It's really interesting to know what to expect in order to make a plan how to treat the advanced colorectal cancer. Because unlikely the other cancers, the advanced colorectal cancer is a disease that is spreading rapidly, and it's affecting a lot of different organs for a short period of time. The younger the patient is, the more advanced and the more aggressive the tumor is. And as I said, there is a circulating cells that can spread the tumor in a lot of different and abnormal organs. And so what now? What to do? What was yesterday and what is going to be tomorrow? Sometimes the hardest thing is the right thing, as you know. On this diagram, you can see what is one of the guidelines that I found, which people are using for unresectable colorectal cancer, which is usually to start a chemotherapy. But I think this is an old guidelines, as you can see, because when you're talking about the rectal cancer, things are a little bit more different, mainly because in the rectal cancer, you can use the radiation treatment. But clearly, if a patient is not a stable candidate for surgery or like a chemotherapy, what's next? The next is that you need to know, you need to still continue to find, because you can treat it and you can beat the cancer. But nowadays, what are our treatment options? So the Japanese guidelines is if you have a resectable cancer, you need to resect it irrespectively where the cancer is. And if it's unresectable, you need to make it resectable. Usually, it's a combined decision that needs an MDT. And as you can see here, the MDT is not only being like involving only the surgeon and the medical oncologist, but in some MDTs, they're also putting the patient, because in the end of the day, the patient is the most important person, in my opinion, in that MDT. The first line is the chemotherapy. I will briefly just mention different drugs and types that are approved for the treatment of colon cancer, starting from the old 5-FU, going to the capecitabine, oxaliplatin, and the new TP-serial and trifluridine. For the metastatic colorectal cancer, it's very important to know the RAS mutation, whether it's a wild type or it's mutated, in order to know which are the first line, the second line, and the third line. This is the guideline that we're using usually here in the UK, which is mainly explaining how to start. Usually it's a FOLFOX or FOLFIR, depending on every single patient. And then if you start with one, you can always like cross over and do the other one. When we're talking about colorectal cancer, it's very important to know whether there's any lymph node involvement or not. As you can see on this diagram, the lymphatic invasion, when it's positive, it has a much worse prognostic value on how your patients will behave long term. The trends in survival is always like worse going when we're talking about the advanced colorectal cancer rather than the early one, which is expected. But it's very important also what type of treatment you're using. That's why a lot of people are making a lot of trials trying to identify what is the right treatment for every specific patient. But in my opinion, it's very important to know exactly how to treat it. And the first line is to identify whether the tumor is already metastasizing in the liver. 30 years ago, that picture that you can see on the right and that picture that you see on the left was completely considered incurable. Nowadays, we have a lot of treatment that we can offer when we're talking about metastatic liver deposits, like radiofrequency ablation, microwave ablation, cryoablation, chemoembolization, or radioembolization. The new area of development, which is the SPRT, or the hepatic artery infusion pump. What is the radiofrequency ablation? Just briefly, the radiofrequency ablation is a device where you're inserting a probe into a metastasis, and the electrodes will deliver a high heat, which will practically burn the tissue and making a scar. But it's only applicable, as you can see here, for oligometastatic disease, which means 1 or 2 big metastatic deposits, which are easily detectable with the ultrasound probe. The next option that we can have is the microlife ablation, which is similar to the one that I described, with the main difference that instead of an ultrasound here, they're like developing a faster heating with a short period of time, but the result is actually the same. Cryoablation is, instead of using a high temperature, we're using like a low temperature, where in the most of the cases, we're using a gas that is up to 190 degrees minus Celsius, which are passed through a probe, and the idea is that it will freeze the tumor and the cancer cells will die. Chemoembolization, or what is called a TASE procedure, is a mixture where, as you can see on the left part of the diagram, when you have a big tumor in one of the liver segments, you can inject a microspheres, which will practically deliver the chemotherapeutic agent directly to the tumor. What is the radioembolization? The radioembolization is a new method which is delivering microspheres of radioisotopy 90Y, which is practically going to directly affect the tumor through the bloodstream. The idea of this is that you can have a higher dose radiation treatment rather than directly irradiating the tumor from the outside. And it's also maintaining a low dose radiation to the surrounding tissue, which is even better to protect the surrounding tissue. The new developed treatment modalities as a stereotactic radiation, it's a new method in which the cancer can be treated by delivering an extremely precise and very intense dose of radiation. As you can see here, it's a lot of 3D imaging that has been designed in order to allow the machine to beam and put all the necessary irradiation into a certain pattern and decrease the level of exposure of the surrounding tissues. It's not a treatment option for patients who are unsuitable for surgical treatment later or an ablation. And it's only been unfortunately offered in a very high specialized training center because this is a very costly procedure. In order where none of the mentioned treatment options are available, we can use what is called the hepatic artery infusion pump, which is an implanted device about the size of a hockey puck, which is practically an old technology in the new era because it's very, it was very popular back in the days, but now people are reimplanting it. And it's designed to give the chemo the concentrate for a liver for a certain period of time. The good thing about this method is that it's allowing the higher dose of the chemo to be delivered to the liver, and it's actually decreasing the exposure of the other cells from the chemotherapy. It's also help us to limit some of the side effects of the chemotherapy, because in this case, we're just delivering that chemotherapeutic agent only and mainly to the liver. That is how the device looks like. Usually it goes through the brachial artery or directly into the hepatic arteries. And again, as I'm a surgeon, I need to offer the surgical options. And as you can see here, it depends, first of all, you need to stage your patient well. And these are the different surgical options which are related with the liver metastatic disease, starting with metastasectomy or wedge resection, segmentectomy, left or right hepatectomy, or like multiple resections. The most important bit is that you need to remind yourself that it's not that important that you need to resect something. The most important thing is that after you resect something, it needs to remain a viable organ. So we cannot remove the whole liver and then the patients will die. So if you remove a certain amount of the liver, you need to have a viable and sufficient amount of the liver remnant left in order for that patient to have some quality of life. And as I said, it's very important that you need to make a proper preoperative imaging and staging. So usually what we're using in our hospitals is it's starting with a CT scan, which is always a dedicated chest, abdomen, and pelvis. We're doing an MRI liver. If we're talking about a rectal cancer, it's also MRI pelvis. We're using a duplex ultrasound as we need to stage and find out what the liver remnant will be left. Sometimes if we have a lot of lymphatic disease, we're always using a PET scan in order to identify if there's something else that we cannot see on the other images. And depending on the liver surgeons, sometimes they're using an intraoperative ultrasound. The patient factor. The patient factor is very important because, as I've said, in the end of the day, he is the person that will take all the consequences from our decisions. So we need to make and plan our operations quite clearly, starting with the age and the comorbidities, where the primary tumor is, localization, lymph nodes, number of metastatic disease, and also assessing the clinical risk scores. Intraoperatively, what we're looking for is the blood loss, the anatomical versus non-anatomical resections, and the pathology margins. What is the clinical risk score? The clinical risk score is to identify all the comorbidities related with the patient, starting with the preoperative evaluation, assessing the neoadjuvant treatment. And in certain cases, what we're doing is we're organizing a diagnostic laparoscopy in order to find out whether a certain patient is resectable or non-resectable. We cannot always count on the CT scan and the MRI scan in order to identify whether some patient can be treated or not. As you can see here, is on this diagram, it's showing the survival based on the clinical risk score and the size of the tumor. So the bigger the tumor is, the lesser the survival is. Also, what I've said is that number of metastatic disease is very important in order to identify the potential prognosis for the patient. So on those two slides, you can see that the survival time is always worse when you're having more than 3 metastases. And as I always wanted to say, decisions are much more important than incisions. And I'm saying this mainly because you need to know and how to plan things before you're starting the treatment. As you can see, this is a brief introduction into our MDT pathway, where, as I've said already, from the Japanese approach, if you have something that you can resect, it's better to resect it and take it away safely. If you cannot, make it resectable, whether by doing a neoadjuvant treatment or like a radiation treatment. And in the end of the day, if a patient is untreatable with an unresectable cancer, we can always do a palliative treatment. There's a lot of different guidelines that you can see, especially related to the liver metastatic disease. As you can see here, it looks a little bit tricky to find out what exactly the guidelines is. But if you're having more than 4 liver metastases, it's always useful to start the preoperative chemo before going into a surgery. Same pathway, as you can see from the German guidelines, identifying like liver metastasis of colorectal cancer. And same from our pathway here in the UK. And as you can see, even in this guidelines, you can see the actual treatment options that you can develop based on whether it's an oligometastatic disease or multiple metastasis, and especially related with the diameter and the size of the cancer. What are the local treatments that we can offer? As I've already mentioned, starting with the radiofrequency or cryoablations or microwave ablations. But in my opinion, if something can be resected, it's always useful to have it resected. The most important bit, as I'm always saying, is the MDT discussion. And every single case needs to be run through an MDT. And in every MDT here in the UK, we're always having not only like general surgeons or colorectal surgeons, but we're always having a liver surgeon as well on standby in case we need their opinion. This is the ESMO guidelines associated with colorectal cancers. And as you can see here, our goal is always to make the patients fit with the outcome of clearly resectable disease and clearly resectable metastatic disease. But in case that you're having a lot of pit stops and pitfalls in your pathway, you can identify how and where. And what I'm saying is mainly you need to know where your cancer is. You need to know how many of the disease have been spread, where exactly in order to plan. And as you can see in this diagram, this is clearly stating that when you're having a different metastatic disease and start with treatment, the cancer itself start changing. And by changing, I mean that from having a cancer who is treated with initially with FOLFIRI or FOLFOX, and then make a new genetic testing of that cancer, you can identify that practically all the tumor cells have changed completely. And on this diagram, I wanted just briefly to mention that it's always better if you can have a liver transplant after a high tumor load rather than making a protoviral embolization and case procedure. So when I'm saying testing, what exactly is the gene testing? The gene testing is a mapping in which you are practically making a lot of different tests to try to find out what the tumor genome is. And why is that important? It's very important because the tumor genome can now, in the modern medicine, give you a guideline. As you can see on this diagram, this is one of the pathways, and this is the other of the pathway, where we can identify what the best possible treatment will be. And especially on this diagram, you can see that there is a difference in between the primary tumor and the metastatic tumor, which is important from the perspective to find and plan what the best approach will be, whether a primary treatment will only be the surgery one, or the primary treatment will be a surgery after chemotherapy. And this is the one that we're using here, where we're taking a lot of samples and trying to identify the proper gene in order to plan our treatment. This is the one that the ESMO guidelines are recommending for colorectal cancer. And as you can see, there's a lot of different genes and patterns that people are identifying in order to plan the treatment. What are the new options? The new options is the immunotherapy, in which people are taking and removing the T cells by leukapheresis, identifying the genome of the tumor, as I've mentioned already, and we're making a new drug that is practically being infused into the patient with the idea that it's going to cure the cancer. On paper and on documents, things are very, very idealistically good, but the reality is not exactly like this, because as you can see here, the immunotherapy efficacy is not as full as expected, but I think people are still working on it. And from 2004, where the first immunotherapeutic agent has been introduced, coming to 2020, there's a lot of different drugs that have been tested. And currently, as you can see, there's a lot of different pathways that people are using those drugs in order to find the best possible approach and outcome. Clearly, our idea is by maintaining that drug that we can identify the right pathway which will give us the best possible outcome in treating that cancer and making it at least progression to stop, or at least to put the tumor on hold. And as you can see here, there's a lot of different therapy and a lot of different factors that people are trying and work on, mainly in trying to identify what the best suitable drug is. For example, for pembrolizumab, which is a new drug, comparing his effect and progression-free survival comparing to the regular chemotherapy, as you can see, there is a huge improvement in the progression-free survival comparing to the regular chemotherapy. Sometimes even that aspect and that type of treatment is not working. And I think what is very important is to know the mismatch repair and the tumor genome before you're starting this. At the moment, there are a lot of trials that are still ongoing, and as you can see here with all the new drugs comparing to like some of the regular chemotherapeutic agents. And this is one of the latest ones that people have published in 2019. It's still ongoing. It's a lot of hope is being put into that study, but I'm not really sure what the outcome is. Hopefully, we will know within the next few years. These are all the studies have been published up to now with a lot of different agents, which are showing obviously that the immunotherapy is also an option for metastatic colorectal cancer. This is one of the studies that have been recently started in MD Anderson, which is mainly for the metastatic colorectal cancer in relation with resectable liver metastasis and unresectable lung metastasis. And lastly, I wanted to put your attention to something that is new, which is a therapeutic potential, which is still ongoing as an experimental bit. It's mainly dedicated to the colorectal cancer. And the idea is that we can do what is called an HUB organoids, which is a new cells having the same idea and the same therapeutic approach as the immunotherapy. Lastly, I wanted to mention that the cancer treatment is a team play game. It's not for solo players, so you always need to have a dedicated team fighting with the cancer. This is how a metastatic colorectal cancer looks like from the inside. And this is my old team who was mainly doing the metastatic colorectal cancer in India. What is the peritoneal malignancy? The peritoneal malignancy is a disease where the peritoneum has been affected by a lot of different diseases, mainly when we're talking about the primary one, it's mesothelioma or peritoneal carcinoma. But in this moment, I want to focus your attention mainly on the metastatic ones. And as you can see, I've put in red the colorectal one. So this is how the peritoneum looks like, as you can see on the picture on the right, when it's been affected from the colorectal cancer. The treatment options that we can have is what it's called a cytoreductive surgery. And the cytoreductive surgery is mainly to decrease and debulk all the visible cancer cells, followed by hyperthermic intraperitoneal chemotherapy, or what is called a HIPEC. The main HIPEC agents used is mitomycin, oxaliplatin, and cisplatin. Treating the peritoneal malignancy needs a very specialized and highly dedicated unit with a full set of the MDT and the intensive care anesthetic department. It's a very long and time-consuming operations. The usual time is between 6 to 10 hours. The mean hospital day for those patients is between 10 days to 2 weeks. And the disease-free and overall survival depends mainly on the histology and the outcome of the operation. So the preoperative setting that you need to know is, as you can see, blood testing, including embryonic antigen, CA99 and CA125. We need a full setting of the all imaging that are available on the market. We need a full colonoscopy to make sure that we're not excluding some simultaneous cancers. All the cases that are going needs to be discussed and on the MDT, including calculating the PCI score. And the PCI score is the peritoneal cancer index, in which most of our patients underwent a laparoscopic assessment. So we're putting the camera in and assessing A, is that tumor spread everywhere? B, is that tumor potentially resectable? And C, what the potential outcome will be from a resection like this. And when I'm saying resectable, our main goal is to identify whether the small bowel mesentery, the small bowel at all has been spared or not. Because I think this is our limiting factor. If the small bowel is not spared, we cannot do anything about it for this patient. Usually that's how the scans of our patients looks like, as you can see, with a lot of disease everywhere inside the belly. And I can just briefly show you one of our videos from one of our surgeries that we're opening a belly of a patient with a lot of peritoneal disease and ascites. I'm just going to briefly run it through. We're making the laparotomy, and all of a sudden now you're going to see that we start taking a lot of tumor deposits and cells. As you can see, this is a huge ovarian deposit after a colon cancer. It was measured to be 19.7 kilos, massive one, as well as around 20 liters of carcinoid ascites. Let me just see where we're actually removing the tumor. Oh, yeah, so this is the tumor has been removed, and it's only the right ovary. And in this moment, I can say thank you for your attention, and I'm more than happy to take any questions.
Thank you so much, Danko. So it was a question from the audience, and the question is, what kind of complications was after the insert of port to the hepatic artery?
So First of all, inserting the port into the hepatic artery as a complication is always bleeding. You can have a thrombosis. It's usually has been done as a palliative statement. So most of our patients have been tried to be treated, as I said, with resection or like a regular chemotherapy. So using the portal cut into the portal artery or the hepatic artery is usually as a last resort. So usually those patients are very frail, and the idea is to try at least to give them some quality of life in the end. But I think talking directly, the most potential complication is probably bleeding, portal vein, forming a clot in the portal vein or in the artery. Well, I think we have one patient who developed an acute liver failure and unfortunately passed away.
And the second question was, how did you manage with it? I mean,
the complication.
How you made, with complications.
So if we're talking about bleeding, usually the bleeding, because we're inserting into the arterial vessel, the bleeding is always obvious and you can stop it on the operating table. The problem is when they're developing late complications like clots, and then we're using a high dose of anticoagulants. And as I said, unfortunately, one of our patients developed like a liver failure. So he passed away, so we couldn't manage that complication.
Если у кого-то есть вопросы, вы можете задавать нашему лектору. Если вопросов нет, мы можем завершить сегодняшнюю школу онтологии. So I think there is no questions, so we can finish our lecture. Thank you so much for so interesting presentation. Bye-bye.
Bye-bye.